Thank you, Jim. So this is one of the questions we get asked all the time. At UCSF, we have a pretty robust program that we've developed over the past couple decades. And the introduction to this is something that we don't need to dwell too long on, but that there's an obvious disproportionate burden. The musculoskeletal conditions disproportionately affect those in lesser resourced areas. The problem of mortality is clearly there. You'll frequently hear that the death rate of accidents is higher than HIV, malaria, and TB combined. Their bigger problem of this is even that there are disabilities that occur as a result of these accidents. So that's even greater and has greater impact than just mortality in and of itself. The lack of access is also very clear. The darker red that you see on this map are those areas that have a proportion of population with less access to surgery. And you can see it's absolutely substantial. And there is also a delay in care that exists both in seeking care, reaching care, and receiving care. So there is a desire to be part of the solution. This is a study that we just completed through the organization that Jim had mentioned, the Consortium of Orthopedic Academic Traumatologists. I'll mention a little later on. But the number of respondents that were residents, we polled 30 different departments that had the residents actively involved in some sort of global outreach activity or introduction to that, and still those residents felt, almost 3/4 of them felt, that there still could be more in their department. So there's a real desire to be part of the solution. So the remainder of this talk, we're going to go through something that was published in the Orthopaedic Forum. This again was through the group of COACT that we had, and we'll go through the 5 different areas: clinical care, disaster response, surgical education, clinical research, and advocacy, and talks specifically just points about challenges, solutions, and considerations. If you're interested, you can go back to that article to review it. From a clinical care standpoint, this is obviously something that orthopedic surgeons really feel comfortable doing. They would like to get involved. They have skill set. They think they can apply it in a way that will help humanity. But there are certainly a variety of clinical care challenges that are both societal and individual, and they range from urbanization, things that you cannot control that are societal activities, infrastructure resource limitations, the situations at these individual sites that range from corruption to just poor conditions, and then cultural ones, and a whole host of implications that range from prevalence of musculoskeletal injury to a local distrust in the care that people are receiving. You can, this is that same map. If you compare the red part of the map with the blue part of the map, where it indicates that people are actually volunteering, a lot of these places are covered, but you can see there's a massive part of the map that just is not covered yet. And so orthopedic surgeons feel very comfortable then about trying to engage in some sort of activity. This is probably the biggest question we get, is how can we get involved? We did a literature review and reviewed the internet looking at, and if you're interested, you can look in this this publication in JBJS that summarizes all the ones that we're able to find, ranging from the amount of time to what their purposes were. And clearly there are obvious ways that people can get involved. The best ways to get involved are through organizations. These organizations have infrastructure already set up that are clinical, but a lot of times they also provide other aspects of support that can be done that include financial, technical, material, and technological aspects. Here at UCSF, we have our Institute for Global Orthopedics and Traumatology, which we've had for over a decade and a half, that tries to collaborate with these different groups, and you can contact any of them as well to try to get more information about what you can do. Clinical care considerations, these are extensive but extremely important in managing. There's clearly a lack of financial aid on both ends, going there and also once you're there. Poor facility support, there could be corruption, theft, personal safety issues, and potentially unfavorable local conditions. Disaster response is a clear way that people have been involved in trying to do volunteerism. These are they're based on timeliness of having an event, and there's a variety of different publications that have talked about the pros and cons of this. when there is a mass casualty event, it overwhelms the regional healthcare capacities. They have to go even to a greater degree of population-based care and conserving their resources. Unfortunately, well-meaning but often unaffiliated volunteers show up at the doors without credentials or logistical provisions, and this can actually be a resource drain instead of an area of support. Organizations are, again, a good solution for this. The outreach work, as we mentioned, is directly translatable to disaster response. These organizations, in their own way, all are helping coordinate this, and one of the benefits is that there's a predictability of them, and they're able to crosstalk between organizations and often already have their tentacles intertwined with local providers and local governments, and they're able to navigate things in a lot better way. Clearly, the military response that Jim has talked about in the past talks about how even safety and security can be done in collaboration with these different groups. So some of the considerations that need to be taken into account is the service that's being provided necessary or appropriate? What are the personal motives of the individuals who are actually going to provide these services? What are their qualifications? What are the risks and procedures of them trying to do something that may or may not be supported by the local environment? And what are what's the ability of the local environment or the surgeons that are left there, the healthcare providers, to provide adequate postoperative care once these individuals leave? The third area is in surgical education, and this is an outreach of clinical care, and frequently also orthopedic surgeons feel like they can provide some expertise in educating the groups that they're participating with in these volunteer missions. The volunteer surgical missions clearly provide a safe and cost-effective health intervention, but the surgical missions can also be problematic, and they can perpetuate dependency, disrupt local dynamics, and be difficult to sustain. And this is where developing some sort of local sustainable solution through education can be helpful, because you're training a local surgical or the local teams, the provider teams, to provide the capacity that these volunteers otherwise would normally be providing. There's a whole host of organizations that do that. It's universally accepted that across different specialties and areas of medicine, that education is the most valuable and durable contribution to some sort of mission, be it surgical or medical, and that these sustainable and constructive partnerships should be centered around education that is specifically programmed to equip trainees with resources that they can utilize that are available to them and are directed towards their improvements, not just the ones that the teachers come in and think that they can participate. It's frequent that we hear that those who are going to these different areas learn as much as they're able to teach. And so these bidirectional partnerships are extremely important. I'll bring up clinical research next. A lot of individuals don't feel like they can participate in clinical research, but one of the core principles is that we don't know what we're not able to address what we don't understand. And we do know that global outreach in research, just like in clinical work, remains undersupported and underrepresented. The studies from high-income countries don't necessarily translate to those parts of the world that are lesser resourced, and often you need to leverage the resources that exist in a high-income group to those of lower incomes to develop local research capacity. There's a huge number of barriers. This has been published before. This is an article that we published in Latin America based on a consortium. Everything that you could consider, from time to ability to actually conduct the research, are really important. So conducting research studies are a way that we can work with individuals, and if you can help provide a network or a infrastructure, it becomes much more capable of addressing the research projects that you're trying to execute. This is another solution that we worked together in Latin America through our organization here at UCSF. Is ACTUAR, the Association of Trauma Surgeons in the Americas. We founded it in 2017. Initially, we were 30 members. We now have over 200 members in 20 different countries. And in 6 years, we've published over 26 articles for research projects that are relevant to the local populations and are trying to change culture to be able to influence people looking at problems that are related to them and empowering them to do that. When you're doing these things, just like in clinical activities, you have to make sure that it's bidirectional. So the partner institutions have to be involved in all stages of the research, so they're learning and they're growing in their own capacity. They need to be active members and represented in authorship, often as first, last authors or presenting authors. And they have to be given access to the raw data so they can use it for whatever they would like to use it. The biggest problem is that there's a lack of funding. And we know this well. Dr. Scherer has a NIH grant that isn't really an area that's for us in the United States is sustainable. So partnering with different institutions and potentially philanthropic organizations are really critical. And we know that right now trauma accounts for only a fraction of the 1% of global health dollars, despite the fact that we just talked about all those things that from a population standpoint are important considerations in musculoskeletal health being a burden of disease. So this brings us into the last piece, which is advocacy. There are a variety of challenges that exist with advocacy. Frequently trying to interpose the high-income country healthcare quality and access efforts don't necessarily translate into successful approaches for lower-income countries. The political climate is often difficult to navigate, and local advocacy for policy changes are imperative, but they involve a local infrastructure. And then you have all those other key obstacles that we just talked about earlier that are influencing this as a problem. So again, organizations are a potential area where people can get involved with to develop potential solutions. They range in all of these areas. These are just the ones in trauma, but they project widespread efforts to improve equity and sustainability. They have the technology that they can use for digital platforms, or it's now available very accessibly to the whole world. And they can also support and conduct some of the research that we just talked about. This is an organization that we have developed here at UCSF that Jim just referred to, and ones that we've done a couple of projects with that I've presented. We have a group of 30-plus North American academic institutions that collaborate through a network. We should meet more frequently than we do. We meet 4 times a year. But the intent is to promote communication, collaboration, and advocacy to allow for some of these activities to go and really coordinate the efforts. Financing's huge. Another way you can participate is by donating. So you can donate through a variety of these organizations, or you can advocate for increased funding. Some of the ones that we've tapped into include the AO and the Weiss Medical Foundation. These are not prevalent enough, but certainly are areas that we would benefit from. So in conclusion, you can get involved. There's a whole host of ways to do this. And if you have any questions about this going forward, please let me know, and we can get you some direction through one of the organizations that might be locally available to you, or ones that we're aware of. So thank you very much.